Hi guys, welcome to Preparator NEET SS. Dr. Patil here, and in this video module we will be learning about allergic bronchopulmonary aspergillosis purely from the perspective of MCQs for upcoming NEET SS examination. Okay, now before we do a little deep dive into the topic, let us take an MCQ. Let us see if we can address that. If we can address, well and good. If not, anyway, we will be revisiting this question. Okay, question goes like this: which of the following is obligatory criteria for the diagnosis of allergic bronchopulmonary aspergillosis? So these kind of questions are very frequently asked of late in last 3 or 4 years in super specialty entrance exams. And you have to remember a diagnostic criteria called as ASmhas criteria for diagnosis of ABPA. Most of these kind of questions can be addressed if you're aware of what ASmhas talks about for the diagnosis of ABPA. There are other criteria like CFS or Cystic Fibrosis Society criteria, and then there are certain previous criteria also which are not that important. Anyway, CFS is quite similar to the ASmhas criteria, so mostly you will not go wrong even if you address a CFS question from the ASmhas criteria. Okay, so let us see the options. Serum IgE levels greater than 100 nanograms per ml. Remember, it is asking about which of these is an obligatory criteria, that means mandatory criteria, right? Okay, serum IgE levels more than 1000 nanograms per ml or precipitating antibodies against Aspergillus fumigatus species. Okay, the third option is Aspergillus skin test positivity, prick test positivity. And the last one is the serum IgE levels elevated against Aspergillus fumigatus species. Okay, so which one of this is obligatory criteria? If you know the answer, well and good. If not, anyway, we will come back to this question. Now let us talk about allergic bronchopulmonary aspergillosis. I always keep telling my undergraduate students that the name of the disease itself holds a lot of information about the disease. For example, in this case also, right? The name goes allergic bronchopulmonary aspergillosis. So that means we are talking about an allergic condition, right? So we are talking about an allergic condition, and what kind of allergy we are talking about? We are talking about type 1 hypersensitivity reaction. Type 1 hypersensitivity reaction. So that means you're talking about an IgE mediated reaction, right? Type 1 hypersensitivity reaction. So that means we're talking about an IgE mediated. So it is an allergic reaction mediated by IgE, right? And there must be some involvement of eosinophilic inflammation. So going forward, you have to remember why we consider eosinophil counts in the diagnostic criteria, why we consider the IgE levels in the diagnostic criteria. That's because we are talking about type 1 hypersensitivity reaction, right? Now, where is this reaction playing out? The reaction is playing out in the respiratory system, mainly the airway, right? That's why the name says bronchopulmonary, right? And this hypersensitivity reaction is triggered by what? It is triggered by the presence of Aspergillus fungal elements, right? We are talking about the Aspergillus fungal element. Now, which species of Aspergillus? We're talking about Aspergillus fumigatus. Aspergillus fumigatus. That's the species. We're not talking about the Aspergillus clavus or any other species of Aspergillus. It has to be specifically fumigatus. Okay. Now, which are the patients who are at risk of developing ABPA? Basic thing we are already familiar. In terms of risk, we need to remember two important entities. Number one is your bronchial asthma, right? And we have to also remember that this is the most common predisposing condition for ABPA. Most common predisposing condition for ABPA. Okay. Apart from that, the second entity we need to remember is cystic fibrosis. Cystic fibrosis. Okay. Do you need to remember the third entity? Yes, I want you to remember the third entity, that is your chronic granulomatous disease. Not strongly associated, but still you need to remember chronic granulomatous disease or CGD. Okay. Now, if you look at most of the diagnostic criteria, they do talk about the predisposing condition, and mostly they talk about these two entities only because commonly those are the ones which are associated with bronchial asthma and cystic fibrosis. Okay. Now, clinically, how this ABPA is going to present? Clinical features wise, you need to remember two things. One, the story of a patient of ABPA is characterized by frequent flare-ups and baseline continued activity. So during flare-ups, mostly it presents in the form of difficulty to treat underlying condition. Difficulty to treat underlying condition. Now, what do I mean by that? Okay, if you're talking about an asthmatic, right? If you're talking about an asthmatic who was generally well controlled with a combination of ICS plus formoterol or any other long-acting beta agonist, now the control is lost once the allergic bronchopulmonary aspergillosis starts occurring. And after that, the same medications are unable to control. It keeps requiring the escalating doses of medications and eventually land up with the need for oral corticosteroids. That's the usual story of a patient of allergic bronchopulmonary aspergillosis in an asthmatic. OCS required in case of bronchial asthma. Similarly, patients of cystic fibrosis, frequent flare-ups, and difficulty to control the underlying condition. That's how that cystic fibrosis patient is going to present, right? Okay. Apart from that, the persistent baseline activity of the hypersensitivity reaction, right? When Ig is produced in large number and when there is eosinophilic inflammation, right? The end result of that is increased mucus production, and this increased mucus production leads to clogging of the airway, mainly the bronchioles, and this can also lead to development of bronchiectasis, right? This can lead to development of bronchiectasis. It can also lead to atelectasis of the lung segments which are not ventilated because of the blockage of the airway, right? So bronchiectasis is one more manifestation that you need to keep in mind. So if you see an asthmatic who is not well controlled and having some bronchiectasis, that may be a pointer towards the allergic bronchopulmonary aspergillosis. Okay. And when you talk about bronchiectasis, you should also know what is the nature of bronchiectasis and what are the segments of the lung that are affected. So bronchiectasis here is mostly cylindrical. We are mostly talking about cylindrical or what is called as tubular bronchiectasis. Cylindrical bronchiectasis, it is mostly proximal or central more than peripheral. So you don't see these bronchiectatic changes occurring towards the chest wall. It is more towards the hilum, right? Proximal more than peripheral. Or you can call this as central bronchiectasis, right? And it is usually upper lobe predominant. So upper lobe predominant towards the hilum, that is the bronchiectasis we are seeing, right? And you might have the radiological evidence of bronchiectasis, and the presence of bronchiectasis may also be associated with copious expectoration and frequent infectious exacerbations. So that's the usual story of the patient, right? So please remember, most important thing is when the underlying disease like asthma is becoming increasingly difficult to control, you should keep allergic bronchopulmonary aspergillosis also as one of the important differential diagnoses, right? Okay. Now, what are the investigations that need to do? We need to do number one, IgE levels. We need the serum IgE levels. Then we need to do a complete blood count to basically look for the presence or absence of eosinophils. And number three, we might need to do a chest X-ray, right? Chest imaging is kind of important because ABP is not the only diagnosis when you think of a difficulty to treat asthma. There are various possibilities. Most common possibility being obviously the compliance to medications or faulty device technique. And apart from that, certain underlying infections or recurrent infections as cause for poor control. So you will also end up doing the chest X-ray. These are the bare minimum things we need, right? So when you do chest X-ray, what are the findings you're seeing? In the chest X-ray, number one finding you can see is what is called as fingered glove sign or finger in glove sign. This is an important image-based question for the NEET SS. Okay, the second thing you might see is radiological evidence of bronchiectasis, better appreciated obviously on the HRCT chest, but chest X-ray might have some evidence of bronchiectasis. The third thing you might see is what is called as fleeting pulmonary opacities. Okay, now why these manifestations are occurring? The finger in glove sign is mainly because of the, like as I've already told you, in case of ABPA, there is increased production of mucus as a response to IgE mediated cell injury as well as the eosinophilic inflammation. There is increased amount of mucus production. As such, bronchial asthma and cystic fibrosis, they are prone for increased amount of mucus production. So this large amount of mucus gets inspissated in large airways, right? So that leads to what is called as finger in glove sign. You can appreciate that in this image. Can you appreciate this gloved finger-like appearance? Right? So this is exactly what is called as finger in glove sign, and this is mainly because this airway is now loaded with the mucus, and that's why it is giving a slight opaque view resembling the fingers placed in a glove, right? Finger in glove sign or gloved finger sign. That's the first radiological sign. Okay, second we will be talking about the evidence of bronchiectasis. I will show you a HRCT image where we will learn a little bit more about it. The other thing is fleeting pulmonary opacities. There are few conditions in the respiratory disorders where we see fleeting pulmonary opacities. A reasonable number of them have eosinophilic inflammation. So these fleeting pulmonary opacities are The opacities which keep changing its location on the chest X-ray at different point of time during the follow-up, because it is not permanently affecting one segment, right? So it is either because of the eosinophilic infiltrates. That's one possible explanation why infiltrates are fleeting. So infiltration of eosinophils occurs in some part of the lung. From there, eosinophils disappear and they again reappear in some other location, right? That's one explanation. The other possibility is the collection of the mucus itself, right? The one thing that was responsible for the glowed finger sign, the same thing, the collection of mucus in some airway segments causes a little bit of atelectasis, and this the airways which are inspissated with the mucus, they are also giving the opacity. But body has inherent mechanisms to clear those secretions, right? So if body clears the secretions from that location, the opacity disappears, but secretions can get accumulated in other location where the opacity might appear, right? So you have to remember fleeting pulmonary opacities in a patient with asthma or cystic fibrosis. You should be thinking of ABPA as also as one of the differential. Yes, various other conditions can also be associated with fleeting pulmonary opacities like sarcoidosis, but the context is very important here, right? An asthmatic or a cystic fibrosis and fleeting pulmonary opacities, my first differential is allergic bronchopulmonary aspergillosis. Okay, so we have already seen an X-ray of the fingered glove sign or finger in glove sign. Now this is the HRCT of a patient, and this is a HRCT of a patient with allergic bronchopulmonary aspergillosis, and here you can clearly see that there are bronchiectatic changes in these locations. They are more proximal or towards the hilum than the periphery, right? You are not seeing them much towards the periphery, and generally they are affecting the upper lobes than the lower lobes. Okay, as I have already told you, they are going to cause cylindric bronchiectasis. So that on the CT gives rise to two important signs. Sign number one is what is called as tram track sign. Tram track sign. So these are thickened and dilated bronchial tree parts which are running parallel, because as I've already told you, it is cylindrical bronchiectasis. It is not saccular or cystic bronchiectasis that we are talking about in case of ABPA. Because it is cylindrical, the dilated segments have a parallel thickened walls, right? So it looks like the railway track or a tram track. If I can see an image, let me show you. Okay, difficult to appreciate here, but the same bronchiectatic segment when end-on view is taken, right? So this was the bronchiectatic segment of the airway that I was talking about. Now, if you take a section here, if the end-on wave is taken, obviously it will look like this, right? What is called as signet ring sign, which you can appreciate here, the ring sign, thickened bronchiectatic segments, ring sign. Okay, and when it is running parallel, we call it as tram track sign. So those are the two signs we need to remember. Tram track sign and ring sign. These may be evident on the HRCT, difficult to appreciate in the chest X-ray, right? Okay, now in this image what you can see is what we described earlier as fleeting pulmonary opacities. Fleeting pulmonary opacities. Okay, so you can see from the image 1, like these images are taken during the follow-up of the patient over several weeks. So in the image 1, you can see opacity is here, a wedge-shaped opacity. Now this opacity is slightly shifted upwards during the second follow-up visit. During the third follow-up visit, the opacity has shrunken and it has become rarefied. During the fourth follow-up visit, it's almost disappeared, only a scanty amount, but during the fifth follow-up visit, you can still see another opacity appearing slightly towards the hilum from the periphery, right? So the starting opacity was a wedge shaped with the base of this wedge on the pleura, right, towards the periphery, and the peak pointing towards the hilum. Now you have an opacity which base is towards the hilum, right? So the opacities are changing its location and form. This is what we call as fleeting pulmonary opacities. These can be either because of eosinophilic infiltration, which itself is changing its location, or it can be because of the mucus collection, which is getting cleared off from the original site of collection and then again getting collected in some other location, right? So when these radiological findings occur in an asthmatic or a cystic fibrosis, you will be thinking of ABPA. Okay, now how we diagnose these patients? The diagnosis, as I've already told you, is based on what is called as ASmhas criteria. We had a previous criteria called as Rosenberg and Patterson criteria, which is no longer followed. Cystic Fibrosis Society criteria, yes, some of us do follow it in a selected set of cystic fibrosis patients. Generally speaking, ASmhas criteria is good to go for practice. Okay, so according to ASmhas criteria, there are three types or three sets of criteria that we need to look at. Number one is what is called as predisposing condition. Number two is obligatory criteria, and number 3 is so-called other criteria or supportive criteria. Okay, the predisposing condition, one out of the two predisposing conditions mentioned should be there. Obligatory criteria, there are 2 criteria, so all 2 should be there, and from the other criteria there are 3, so 2 out of 3 should be there to classify a case as the allergic bronchopulmonary aspergillosis, right? So let us look into this criteria. What are the predisposing criteria? We are already familiar that we are talking about asthma or cystic fibrosis. The chronic granulomatous disease doesn't figure into ASmhas criteria, but if you encounter a CGD patient and he's having typical features of the ABPA, in your individual capacity, definitely you can diagnose the case as ABPA, right? But the diagnostic criteria only talks about these 2, asthma and cystic fibrosis. So one out of this 2 should be present, right? One out of the 2 should be present. Either asthma should be there or cystic fibrosis should be there. After having satisfied the predisposing criteria, you will look at obligatory criteria. We have already understood that this is a type 1 hypersensitivity reaction in a pre-existing asthmatic or cystic fibrosis, and we are talking about the IgE levels and eosinophils, right? Okay. Now, what we need from the obligatory criteria is either aspergillus skin test should be positive, which is an obligatory criteria, or the IgE levels against the aspergillus fumigatus should be elevated, right? So please note, because the question that we have already taken might be quite confusing now, right? Aspergillus skin test should be positive, or if you're not looking at that, the IgE levels against the aspergillus fumigatus, specifically targeted against the aspergillus fumigatus, not the total IgE levels, should be elevated, right? That's obligatory criteria number 1. This is obligatory criteria number 1, and the obligatory criteria number 2 is the total IgE levels, right? This is talking about the total IgE levels. Total IgE level should be more than 1000 nanograms per ml or more than 417 international units per ml, right? Okay, so IgE levels greater than 1000 nanograms per ml is one of the obligatory criteria. The other one was the skin test positivity or the IgE that is specifically against the aspergillus fumigatus, right? Okay, now the 2 out of this 2 should be there, because the name says it is obligatory criteria. Okay, after that you need to look at these other criteria, where you are looking at presence of 2 out of the 3 criteria that are listed here as other criteria or supportive criteria. What are those? Precipitating antibodies against aspergillus fumigatus. So please do not confuse this with aspergillus skin test positivity. Skin test positivity is a obligatory criteria. IgE specifically against the aspergillus fumigatus in the blood is a obligatory criteria. Okay. Precipitants or precipitating antibodies against aspergillus fumigatus is a supportive criteria, right? It's not mandatory. Radiography suggestive of ABPA, which we have already discussed, right? What are the points that we have already discussed? Important signs we have already discussed, right? One is your gloved finger in finger sign or finger in glove sign. The number 2 is your fleeting pulmonary opacities. Fleeting pulmonary opacities, and number 3 is the typical bronchiectatic changes. So these are the radiological findings we are looking at in a case, right? So if radiology is suggestive of, you have any of these, either you have a gloved finger sign or you have the typical bronchiectatic changes or fleeting pulmonary opacities, that satisfies one of the other criteria. The other criteria number 3 is the total eosinophil count. So remember, we were talking about the pathophysiology and we spoke about eosinophilic inflammation. So total eosinophil count should be more than or equal to 500 cells per cubic millimeter, right? Okay, so that's about the diagnostic criteria. Now, before we go to the treatment, let us revisit the question that we had already taken, and then we will talk about the treatment. Okay, so this is a question that we had taken. Serum IgE levels more than 1000 nanograms per ml, right? This is about the total serum IgE levels, and this is definitely the obligatory criteria number 2, right? So this is obligatory. This is obligatory criteria number 2. Okay, predisposing antibodies against Aspergillus fumigatus. Precipitating antibodies against Aspergillus fumigatus was the other criteria, right? It was a supportive criteria or other criteria, not an obligatory criteria. Okay. Aspergillus skin test positivity, that was an obligatory criteria, right? That's an obligatory criteria. Okay. And the raised IgE specifically against the Aspergillus fumigatus, that was also an obligatory criteria. Now we had to make one consideration between these two, right? I mean, the option C and option D are part of the single obligatory criteria. Either skin test should be positive or the IgE against Aspergillus fumigatus should be positive. So they're combined as a one obligatory criteria. One of them present, that obligatory criteria is satisfied, and option A is another obligatory criteria. So option B is the one which is not an obligatory criteria. If the question was asking about which of the following is not an obligatory criteria, option B would have been the right answer. Now it takes the PGI kind of format. So option A is the right answer, option C is the right answer, option D is the right answer. These three are obligatory criteria, right? Okay. Now talking about the management of the allergic bronchopulmonary aspergillosis, there are two dimensions to achieve. Number one is allergen reduction, right? So allergen here is Aspergillus fumigatus, fungal elements, and that we can achieve by offering the patient antifungals. And number two is taming the immune system, which is now manifesting as hypersensitivity reaction. So for that, you can offer corticosteroids, right? Now, can we use one of these like steroids and not use antifungals, or only use antifungals and not steroids? Well, you're right. So mostly what we understand about the management of allergic bronchopulmonary aspergillosis stems from our experience with corticosteroids. Okay. Now, very recently only we have started using antifungals, and studies have shown that corticosteroids are superior in comparison to antifungals alone. When corticosteroids versus antifungals studies were done, what is agreeable is that corticosteroids are definitely superior agents, right? So they had been the mainstay of treatment for several decades, like last 4 decades we had been using corticosteroids for management of ABPA, and they continue to be the most important drug when it comes to the ABPA management. But then what do we achieve by adding antifungals? Theoretically, right, we achieve the reduction of allergen load, and that should manifest in the form of reduction in the duration of steroid therapy. You will be able to quickly taper off steroid therapy, and that's what we can achieve by combining. So that's why currently corticosteroids plus antifungal combination is the most commonly followed practice for management of ABPA. But if you have to pick up one drug of choice, you need to still consider corticosteroids as the drug of choice. Okay. Now, with respect to antifungals, all is sorted out. Itraconazole is considered as the antifungal of choice. Usually 200 milligrams BD for an adult. Total duration of therapy is 16 weeks or 4 months. Okay. Now, what is not sorted is about the regimen of steroids. The ideal dose and the duration of treatment is not sorted. There are various regimens proposed by various studies, and the most commonly followed regimen is what I am projecting here. In this regimen, you will start with around 0.5 milligrams per kg per day of oral corticosteroid. We are basically talking about prednisolone or its equivalent, 0.5 milligrams per kg per day, and we give that for around 14 days or 2 weeks. After that, you start tapering, right? So initial tapering is conversion of the same dose into alternate day regimen. Then subsequently you taper it off. You are trying to totally stop or completely taper it off by the end of 3 months. At the end of 3 months, the steroid therapy should be completely stopped. That's the objective. Can we achieve it in all patients? The answer is no, and other practitioners are free to consider long-term steroid therapy. Right? There are various regimens which talk about initial 3 months high dose, and after that reduced dose for another 3 months, and then after that again slow tapering over several months, like up to 6 months. So the course may run for 1 year, but most cases this may be adequate. So I personally would prefer using this regimen. Okay. Now, if itraconazole is not what you want to consider, then what are the alternatives? You can consider oriconazole as an alternative, or you can also use isavuconazole as an alternative. Okay. What if a combination of steroids plus antifungals fails to achieve the remission? What else can be offered to the patient? Okay, you can offer the patient omalizumab, which is a monoclonal antibody against IgE, right? It's an anti-IgE monoclonal antibody. This can be offered as a second line agent if the first line agents, which are our combination of the corticosteroids plus antifungals, fail. Then you might consider treating them with omalizumab. Okay, so that's it on this video module, guys. I'll be seeing you with the next video module very soon.